not significantly different when the amniocentesis was done between 17 to 21 weeks or after 21 weeks. So our recommendation now is to perform amniocentesis without prior CMV PCR in the maternal blood, and 8 weeks after the onset of maternal primary infection and after 17 weeks of pregnancy. The positive predictive value of CMV PCR amniotic fluid is excellent, very high. The negative predictive value is around 90 to 95% in different studies. So these false negative cases are those with a negative PCR in amniotic fluid, but a positive PCR at birth. And these cases are due to a late transplacental passage of the virus. So the virus, even if the mother had the primary infection in the first trimester, the virus crossed the placenta after the first trimester later. And because the fetal infections came later, these fetuses have a very good prognosis. And we've done a collaborative study with an Israeli group showing that this baby with a late passage of the virus had a very good prognosis with no sequelae at all at 2 years old. Amniocentesis for congenital toxoplasmosis should be done 6 weeks following the seroconversions and after 18 weeks. And also the positive predictive value is very good, and the negative predictive value is around 90–95%. So the negative predictive value for sequela of rubella, CMV, toxoplasmosis PCR in amniotic fluid is very high, with a risk of pregnancy loss that is very low, less than 1 for 1,000. So a negative rubella PCR or negative CMV PCR in amniotic fluid exclude that rubella or CMV are responsible for the fetal symptoms in symptomatic fetuses, and exclude the risk of fetal infection with sequelae in asymptomatic fetuses. By contrast, the sensitivity of Zika virus PCR in amniotic fluid is not so good. There are not many data in the literature, but from the data that are there, you see here a study from, I think it's a Brazilian group. They show that among 23 cases with evidence of Zika birth defect, PCR in amniotic fluid was positive only in 26 of these fetuses. And other studies shows that the Zika PCR in amniotic fluid is more likely to be positive earlier in pregnancy. In 11 women with a positive PCR in amniotic fluid, 50% had a negative Zika PCR in a subsequent amniotic fluid collected 1 to 2 months later. So this suggests that Zika infection is not chronic in the fetal kidney, as is the CMV or the rubella congenital infection, and that Zika RNA may be cleared from the amniotic fluid before the end of pregnancy, while the virus may still replicate in the fetal brain. So a negative Zika PCR in amniotic fluid in a symptomatic fetus does not exclude the diagnosis of Zika infection. And Zika PCR in other sample types may help to the diagnosis. In Zika infected symptomatic fetuses, the PCR is frequently positive in the maternal blood, the placenta at birth or at termination of pregnancy, and the fetal brain at termination of pregnancy. And I've reported here the result of a small series of 8 cases we came across in our center. And you can see for the cases 1, 2, 3, 4, all these fetuses, the mother were infected in the first trimester of pregnancy. And at mid-second trimester, the fetuses presented with fetal brain defect. And the PCR in maternal blood was positive in all those 4 cases. But you see the CT value of the PCR quite high. So the PCR was low positive in the blood, but still positive. The PCR in the amniotic fluid was high positive in the 2 first cases, was sort of medium positive in the 3rd case, and was very low positive in the 4th case. We tested it twice. The first time it was negative, and the clinician was absolutely sure it was a Zika virus infection. So we tested it again, and then it was positive, but very low positive. And when we tested the placenta of those cases, they were positive, but rather low positive. We see quite high CT value of the PCR. And we did the PCR in fetal brain in the fetuses that were interrupted. And you see that the PCR in the fetal brain was extremely highly positive, even in the case with nearly no virus, RNA virus in the amniotic fluid. We go to treatment of fetal infection. So the aim of fetal infection treatment is to avoid the constitution of irreversible cerebral lesions. It should rely on drugs that could be used safely in the 2nd and 3rd trimester of pregnancy. And so far, data are available only for treatment of fetuses infected by toxoplasmosis or CMV. On this slide, you can see the different drugs that we can use to treat CMV infection. In the nucleoside inhibitors drugs, the main drugs against CMV is the ganciclovir or the valganciclovir. It is the first line treatment for we use to treat CMV disease in immunosuppressed patients. It works extremely well, but it is suspected to be a teratogenic drug. So we are very cautious to use it during pregnancy. Valaciclovir, we've talked about before. Valaciclovir is not a very good anti-CMV drug. It's a drug that is targeting herpes simplex virus or varicella virus, but it still have an action, I mean, it's still effective against CMV as a prophylactic drug, but you have to use very high doses. That's the reason why we use 8 grams per day, because otherwise it's not, the concentration is not enough. Other drugs that are quite efficient against CMV is the foscarnet and the cidofovir, but there is no oral formulations, very high renal toxicity, and no way we're going to use that during pregnancy. Other drugs, new drugs, are the letermovir. The letermovir is a drug that targets the terminus of the enzyme. It's a new drug that is available now to for the prophylaxis of CMV disease in transplanted bone marrow transplanted patient. And maribavir is not yet on the market. So if you look at the literature, there is only 2 cases of treatment of CMV-infected fetuses with valganciclovir that have been reported. And they were reported, one by a German group and the other by an American group. And they treated 2 fetuses at very late in pregnancy, in the 3rd trimester, with good outcome and no side effect. In our center, we used valganciclovir twice as a rescue drug in women who were carrying a fetus with very severe CMV infection with fetal brain lesions. And these women didn't want to have termination of pregnancy. So we offered them the valganciclovir treatment. And we had no side effect in the mother. And the two babies were born asymptomatic, which was surprising because they were really severely affected in utero. And they are doing well now at 6 months and 2 months of age and the 12 months of age. One of the baby had a neonatal neutropenia because valganciclovir is known to be neutropenian. Otherwise, a few years back, we did a phase 2 multicenter study testing the use of valaciclovir to treat infected fetuses. This study was not a randomized control study. It was only one arm. All included women were treated with the valaciclovir 8 grams per day up to delivery. In this study, we included 43 women with an infected fetus presenting with mild ultrasound symptoms. And the primary endpoint of this study was the number of asymptomatic neonates at birth. No side effect was reported in the women, although we used a very high dosage of valaciclovir. And the comparison of the study results with those of her historical group showed that valaciclovir significantly increased the proportion of asymptomatic neonates from 43% without treatment to 82% with treatment. So this study showed a plausibility of the efficacy of prenatal valaciclovir treatment, but this needs to be confirmed. And when you look in detail of the result of the study, fetuses with more than one ultrasound symptoms at the worst prognosis with only 57% of asymptomatic neonates in this group, suggesting that valaciclovir had a too low clinical efficacy in this group. Moreover, when we looked at the virological efficacy of valaciclovir, it was only partial. The fetal blood viral load significantly decreased with treatment. However, 90% of treated fetuses still had detectable CMV DNA in cord blood at birth. So we think that this pleads for the use of a more potent antiviral, an antiviral that is more specifically against CMV. And we are doing another trial now, the CIMEVAL-3 trial, which is ongoing. It's a phase 2 randomized double-blind multicenter trial. The inclusion criteria in that trial is to have a fetal infection, a positive CMV infection in the amniotic fluid, and a CMV maternal infection in the first trimester, because we know that there is a 40 to 50% risk of any sequela in the first trimester group. So the patients are randomized between the valaciclovir group 8 grams per day, and the other arm, in the other arm, we're using letermovir at the concentration of 240 milligrams once a day. And we choose that concentration according to the ex vivo cotyledon model, a study that Valentin did, and to the in vivo data of the transplacental transfer in the second and trimester. So 240 millimicrons is enough to reach efficient fetal drug concentrations. In this study, we were following up the infected fetuses by ultrasound every 2 weeks, MRI twice during the third trimester, and maternal laboratory test every week. The endpoint of the trial is the proportion of negative CMV PCR in the neonatal blood at birth. So we'll hopefully get the results of that study in the coming 2 years, I think. Just to resume for congenital toxoplasmosis, because Valentine already explained that very thoroughly. So when you diagnose primary infections, the prophylaxis is now with pyrimethamine plus sulfadiazine or with pyramicin 1 gram three times a day if the primary infection occurred before 14 weeks. Then we do the amniocentesis at 18 weeks. If it's negative, it depends on the team, but either the pyramicin is still used until birth, or we stop, and there is a monthly ultrasound on, of course, a neonatal workup. If the PCR is positive in the amniotic fluid, there is a prognosis evaluations, and if will later shows all the how to do the prognosis evaluations, and if either the prognosis is bad and the termination of pregnancy is discussed, either the prognosis seems good and in utero therapy is done until birth with the 2 drugs, pyrimethamine plus sulfadiazine. So in conclusion, the PCR in amniotic fluid is reliable to diagnose fetal infection. CMV, rubella, I didn't talk about B19, but it's the same. It's very reliable, high sensitivity, high specificity, toxoplasmosis, except for Zika fetal infection, okay, where the prenatal diagnosis is not so sensitive. Treatment of fetal infection, no drug available to treat rubella or Zika infection, and experience reported, but no randomized controlled trial result available for valacyclovir treatment of CMV fetal infections and pyrimethamine and sulfadiazine treatment of toxoplasmosis fetal infection. Thank you for your attention.
Xin trân trọng cảm ơn phần báo cáo của tiến sĩ Marianne Logovin. Trân trọng kính mời các anh chị học viên tham gia offline và tham gia online đặt câu hỏi cho tiến sĩ Marianne Logovin. Trong lúc chờ các anh chị học viên đặt câu hỏi, ban tổ chức chúng tôi xin thông báo về việc khảo sát đánh giá cuối khóa. Đề nghị các anh chị tham gia khóa đào tạo và cấp chứng chỉ có đóng phí bắt buộc phải tham gia để hoàn thành bài lượng giáo cuối khóa. Hạn một bài lượng giáo cuối khóa là trước 16 giờ ngày hôm nay là 17 tháng 8 2002. Học viên tham dự online thì làm bài lượng giáo cuối khóa bằng đường link hoặc là quét QR code. Học viên tham gia trực tiếp tại hội trường thì làm bài lượng giáo cuối khóa bằng quét QR code trên màn hình. Học viên đủ điều kiện sẽ được cấp chứng chỉ CME tương đương nội tiết đào tạo liên tục. Chứng chỉ có chữ ký của giáo sư Igovin và giáo sư Nguyễn Duy Ánh, giám đốc Bệnh viện Phụ sản Hà Nội. Tiếp theo là phần trình bày của giáo sư Igovin ạ. And now is the report of Professor Igovin, please.
Okay, so good morning, and we're going to wrap up the session. The part of the session on infection. With an emphasis on the management, knowing that you've got all the cards for diagnosis, prevention, and the treatment. So again, it's always the same question. Are you just following someone you know has developed a maternal infection? Or are you faced with ultrasound symptoms and you have to think yourself about infection? And these obviously are not exactly fitting with the same strategy until the diagnosis is made. Because if you are prospectively following someone, you will look for the appearance of symptoms, but basically that's not really relevant. You will just have to wait the time from the dating of infection. You will wait 6 weeks or 8 weeks, and then you'll do an amnio and a PCR to just out of a diagnosis, a definite diagnosis. Now, if we move to the ultrasound, which what has not been yet dealt with, all infections, all fetal infections, they will share common symptoms. And those symptoms are timely appearing, but roughly, if you just do a scan, you don't know, again, the beginning of the story if you haven't been screening. So outside the fetus, you will look at the placenta and the amniotic fluid. The placenta is altered because the placenta is the way the fetus gets infected, and the placenta is struggling against infection. So you will get sequelae of the infection in the placenta, and that would be a thick placenta. Usually a thick placenta is a placenta of more than 4 centimeters in the second and third trimester. You would see lacuna or heterogeneity of the ultrasound appearance of the placenta, whichever they are, and I'll show you images. Second to the placenta, still outside the fetus, is the amniotic fluid. There's a common belief that infection gives polyhydramnios, and when you see polyhydramnios, you look for infection. This is a bit outdated, and in fact, oligohydramnios is more frequent, much more frequent than polyhydramnios in infection. And the reason for that is especially the infections we're talking about, which is CMV, toxoplasmosis, varicella. They get to the kidney as the first step of fetal invasion. And when they get to the kidney, they give nephritis, and nephritis decreases urination, and therefore you get oligohydramnios. When it is not a severe infection, oligohydramnios resumes within a few weeks back to normal. But when it is a very severe infection from the beginning, oligohydramnios persist, and therefore oligohydramnios is more evocative than poly. Poly occurs when there is hepatomegaly compressing the stomach, and therefore leading to polyhydramnios by regurgitation or not swallowing, and very rarely through neurological damage, very rarely. Then, because the placenta is impaired, every congenital infection developing, therefore, from the first, second trimester is going to hit the growth velocity, and therefore growth restriction at the beginning with normal Doppler is a very common symptom for infections. At the beginning, the Dopplers are normal, but because the placenta is ruined at some point, if there is growth retardation, if you catch the train in the third trimester, you may have abnormal umbilical Doppler as well. But in the second trimester, they are not. Hepatomegaly is splenomegaly. It's the common defense of the fetuses against the infection for all infections, and then the brain abnormalities. And potentially, when there is a very broad damage to all the fetal systems, and especially through anemia, you get hydrops. So if you think of an infection when you do a scan, you ask for maternal serology. The only, as it was said repeatedly this morning, the only circumstance where you don't have to think about this particular infection is when the IgG are negative. That cannot happen. But if the IgG is positive, then the only way out is an amniocentesis. So which infections are we looking at? CMV, toxo, parvo, herpes, varicella, rubella, Zika, enteroviruses. They all share the common symptoms that I've just said they were. But if we are talking about possibility of treatment, you've heard that before, that's the first three, the top three, and also at least in Europe by incidence and prevalence, but might not be the case here. We'll see. So again, there is, if you go through CMV infection, chronologically, these are the placental abnormalities you're looking at. And then the virus gets to the fetal bowel. And the fetal bowel, the inflammation caused by the virus goes together in CMV with perforation of the bowel. So you could have just bowel paralysis that is transient, that is ileus, and then you get hyperechogenic bowel, or perforation of the bowel, and you get hyperechogenic bowel plus ascites, that is meconial peritonitis. Hepatomegaly, splenomegaly, calcifications. In all infections, calcifications are witnessing the struggle and the necrosis at the point of the virus impact. And those you can find everywhere. You can also get myocarditis with CMV and hydrops. So if you look at echogenic bowel, that is usually what you see whenever you buy a new ultrasound machine, you will find echogenic bowel. So you need some degree of objective evaluation. And unfortunately, artificial intelligence hasn't helped for the last 20-something years, because we are still relying on criteria defined in the early 80s, but it's already something. You compare the bowel to the nearest bone, so it could be the spine, or it could be the femur, or the iliac crest. And once you've frozen the image where you see a bone and you see the bowel, you switch the gain down to 0. And you only consider the bowel to be hyperechogenic if it goes at the same time as the bone or after the bone. Everything else is not hyperechogenic bowel. By doing so, you will find a very low incidence, in fact, of hyperechogenic bowel. And as for the etiologies, most of those do not have a pathological finding, etiology, because they arise mainly from early bleeding in pregnancy with blood in the amniotic fluid, and you can shake the uterus in the second trimester. You see the speckles of the blood moving in the amniotic fluid, and that goes well together with hyperechogenic bowel. If the fetal morphology and growth assessment is completely normal, that is the most likely infection. When you see that, and I don't know which mutation and how frequent that is in Vietnam, but in Europe for sure, we still get the parents to be checked for cystic fibrosis, and we get serologies for infection. And we usually stop there, especially now with, as Mark said this morning, and also Dario yesterday alluded with signs that used to be in relation with Downs. If proper screening has been conducted in the first and sometimes second trimester, you don't need to really worry about that. All severe IUGR cases are going also to show hyperechogenic bowel. So that is for that. But infection is a possible cause, should be considered. The liver you will measure in a parasagittal plane. So between the gallbladder and the diaphragm in a parasagittal plane, so the right lobe of the liver. You have normograms for the last 40 years that are still valid. And for the spleen, it is a transverse view in the abdomen showing the spine, the stomach bubble, and the lowest rib. If you do this, there's a mango shape that is not always visible if the spleen is very small, but an indirect sign of a splenomegaly is that the stomach bubble is pushed toward the middle of the abdomen and not really on the left-hand side. And once you've got those three landmarks, you can measure the largest diameter of the spleen, and it obeys to the same rule as the liver biometry. In essence, any spleen or liver that is less than 30 millimeter during the late second and third trimester is normal. And otherwise, you should question hepatomegaly and splenomegaly. And this is the sketch of a typical infection with hyperechogenic bowel, with splenomegaly, hepatomegaly that is going to be measured. And then you'll see also a heart that is enlarged. There is a thick placenta, and the heart there's some certain degree of dilated cardiomegaly here, not very marked. So all those signs, although if you know you're searching for infection, you will find relevant. If you don't, and you do just an ordinary second trimester scan, that might be very difficult to pick up. The cerebral features with CMV are extremely diverse. They are not all of them significant of a poor prognosis, and we're going to go through that. The most common signs is mild ventriculomegaly, less than 20 millimeter, and calcification, ubiquitous in the white matter. You can also have subependymal cysts, and subependymal cysts are very common even outside infections in between 24 and 32 weeks. This is just a reflection on the migration of the neurons from the germinal matrix to the cortex. So those cysts by themselves are not a sign of severe infection. You can see also the typical candlestick images on a coronal view of the brain, such as here. You've got calcifications of the lenticulostriate vessels, very evocative in the postnatal life and difficult to see before late third trimester on antenatal ultrasound. And finally, another sign is a septation in the posterior horn of the lateral ventricles. These septations are a sequelae of the inflammation of the brain, but again, they are not significant in terms of prognosis. So what I wrote in green are not a no-go in terms of good prognosis. These fetuses might still do very well. Everything above that, especially the white matter damage, periventricular hyperechogenicity, periventricular cyst or cystic periventricular leukomalacia, are definitely very pejorative, and also, and even more so, but very difficult to see on ultrasound if you get abnormal gyration, if you get lissencephaly, if you get polymicrogyria, then this is a very poor prognosis. Microcephaly, you may not see during the pregnancy because, especially if you have growth restriction, the head might not stick out as particularly small, but what you will see, which is very suspicious in a small fetus, if you see enlarged pericerebral spaces. So too much space like here between the brain and the skull, which is microencephaly. This is how microcephaly develops anyway. It's microencephaly with the lack of stimulus of the skeleton to grow above that goes, especially after birth, microcephaly. So enlarged pericerebral spaces are fine in big fetuses because they have fluid everywhere, but very unusual and suspicious in a small fetus. So you've heard about the treatment with valacyclovir. Now, the additional value of MRI is now obvious to all places who have the resources of antenatal MRI, because calcifications and morphology of the brain can be well depicted with ultrasound, providing the lady is actually ultrasound friendly, which is the case in Vietnam, but not always, and far from that for at least 20% of them in Europe nowadays. An MRI is certainly superior to ultrasound to look at abnormal gyration And this is really the cortex that you're worried about if you have minor cerebral ultrasound finding. So MRI is part of it. And what I want to focus on to finish with this talk is by looking at what we call minor symptoms of fetal infection and what is their prognosis with the current antenatal treatment, whether it has been started before the amniocentesis as a secondary prevention, as Valentin has shown you, or it has been started at the time of fetal infection. So just a reminder of a decrease by 2/3 of the risk of transplacental passage with valacyclovir, and then the tertiary prevention that Marianne presented. Once the fetus is infected, if it has been started before the amnio, we carry on with valacyclovir 8 grams per day. If it hasn't been started before the amnio is positive, we give valacyclovir 8 grams per day. Now, what are those? What is the workflow? Preventive treatment, curative treatment after the amnio, then ultrasound every 2 weeks. MRI, we increase the use of MRI, but at least 32 and 35 weeks to see clearly the gyration and the diagnosis of subtle abnormalities there. But otherwise, we have now the postnatal, and the postnatal will be the endpoint to deal about the prognosis in this short presentation. The predictors of neonatal symptoms and long-term sequelae is with CMV. First and foremost is the timing of maternal infection, as repeatedly said, but that's really important. Knowing that if you see ultrasound findings in the second trimester, it means that the infection in the mother happened in the first trimester, because you need weeks for those symptoms to appear. Chordocentesis, as discussed before, we would not really push for anymore, because knowing the timing plus the images would be enough. So these are the signs we're looking at as minor signs: placentalomegaly above 4 centimeters, hypogenic marrow, splenomegaly, hepatomegaly, and effusions, and probably lag of growth. Mild cerebral features again: intraventricular septation and periventricular halo or hypercogenicity, intraventricular septations of the posterior horn, subependymal cyst, and calcifications. When you see that, it is very compatible with the infection you've diagnosed. We look on MRI, and again, on MRI, you can see mild features, which is the hyper signal in the white matter in T2 sequences, temporal cyst, which is basically a focus of this hyper signal at the level of the temporal lobes. These are not actually cysts, and subependymal cyst that you can also depict with ultrasound. Anything above that is severe features and doesn't need to be really detailed. Now, we looked at 100 cases of infections with minor signs, the one I've just shown. The majority were treated before, and the minority did not get the secondary prevention. And we have two groups here: one group with normal imaging, as per the protocol I've given, and the other group with minor abnormalities. And then the development of extracerebral abnormalities only, or cerebral and extracerebral abnormalities, because you can't have extracerebral cerebral abnormalities without having before at least extracerebral ones. Overall, 40% of those had a normal imaging, both MRI and ultrasound at the time of the diagnosis. Extracerebral in 30%, and 30% with both cerebral and extracerebral. Now, if you look at the value of treatment, if you want to assess the value of treatment in normal imaging, no treatment, completely normal imaging, the prognosis is the same. So if you have a full assessment with imaging, whether it is treated or not, the prognosis is equally good. Now, the abnormal imaging, same abnormalities in treated and untreated, that becomes interesting, because those showing abnormal imaging in the group with a treatment, you can see a progression in the prognosis with the value of normal imaging, extracerebral only, and extracerebral plus cerebral. Those have the worst prognosis. And this means that 30% of those will be symptomatic at birth and at 2 years of age, with mainly in 1/4 of them some degree of neurosensory hearing loss. If you compare now the value of treatment in cases with abnormal images without treatment compared to those with treatment here, you will see a difference. For the same abnormalities, you will see a difference at 1 year of age, especially in the symptoms. Twice as many will be asymptomatic in the treated group, although it was not really different at birth. And there will be also the overall neurosensory hearing loss will be the same, but many more bilateral neurosensory hearing loss in the group that did not receive treatment. So to summarize it, with normal imaging, 85% of those infected cases will be asymptomatic, whether they're treated or not, at the age of 1 year. So this is not a poor prognosis overall. And the residual risk will be neurosensory hearing loss, unilateral in the treated group, and 50% bilateral in the untreated group. With those minor abnormalities on imaging, 65%, therefore 20% less, will be asymptomatic at 1 year in the treated group, and it is twice the rate of asymptomatic as the untreated. Only 1/3 will be asymptomatic. And the residual risk will be extremely low and very disputable in this series because the genetic condition is highly suspected in those of neurological delay, and 8% if untreated. The neurosensory hearing loss remains significant, but it is mainly unilateral when there is a treatment, and this is largely bilateral when there is no treatment. So we're making progress. For parvovirus, be very quick, because in the excellent talk on anemia yesterday, Mark Kilby mentioned already the symptoms, which are basically the symptoms of anemia. And he mentioned also the treatment, which is intrauterine transfusion. And just to emphasize that once you've given a transfusion and there is no signs of anemia anymore on the MCA PSV, if the hydrops is not resolving, although the ascites takes a few weeks to disappear in this, and you go from a dilated cardiomyopathy to a hypertrophic myocarditis, you may unfortunately not retain any hope in this pregnancy, because both ventricular cavities disappear in the hypertrophy, and this is that is causing this becoming now a malformation of hypertrophic myocardiopathy, and there is no survivors described in those cases. Also, unfortunately, some of these fetuses will be cured from the parvovirus infection and its anemia, but because they get transfusion with hemoglobin levels as low as less than 1 gram, they may develop post-operatively, post-transfusion, revascularization and reperfusion of ischemic brain tissues, and show ischemic brain lesions or intraventricular hemorrhage. So the follow-up here is extremely important. As for toxoplasmosis, you've heard it all about the diagnosis and the treatment. The semeiology on ultrasound is simpler and more obvious than for CMV, in that the necrotic lesions as witnessing the struggle of the parasite with the fetus are very patchy. They are not thin in any way. They are patchy and they are progressing during the pregnancy. The addition in the semiology that you don't have to fear with CMV are eye lesions, either cataract or macrophthalmia. So in your follow-up of those cases, you will add an examinations of the eyes. And when there is ventriculomegaly, there is no mystery. This is a ventriculomegaly that is very progressive and is not hiding anything. It's not subtle. Again, it's not at all the parvovirus. You will have some help from the MRI if the lesions are not very many, but usually ultrasound is really enough. For varicella, is more common than it used to be 10 years ago, much less probably than 40 years ago. I've been in this job operatively for 30 years. I've seen only one case of severe varicella. I've seen a handful of infected fetuses with no prenatal symptoms, and at birth, babies are just small scars of the rash and the vesicles. But I've seen this one case, and that was nearly 30 years ago. But it is typical of both varicella and severe herpes fetal infection, in which you get fetopathy with hepatomegaly and calcification. You get all the brain lesions with the ventriculomegaly, the hyperechogenic lesions of the ventricles and the brain in general. And what is very unusual is the lung lesions. The lung lesions mimics CCAM. But that was the one case, plus a couple of case reports. But this poor guy, we've also amyotrophy. So if you carry on up to third trimester, you got the skin and the bone, but you don't have any muscle left. So this poor guy accumulated all these problems. But usually varicella doesn't cause any fetal damage, and you don't have to carry an amniocentesis with varicella. Ultrasound examination is enough. As for Zika, Zika is a combination of toxo and CMV. When you've said that, there is no way you're going to miss a cerebral lesions of Zika virus. It's got the eye lesions. It's got all the brain problems you can imagine. And the specific thing is what makes you think of Zika, and nearly Zika only, although herpes does the same. You see, those calcifications are very numerous and grouped. So that's what is evocative of Zika. And to finish with the last slide, Vietnam is not, I mean, there is no outbreak of Zika, but there have been cases of Zika, especially in South Vietnam, and when we're going tomorrow in Da Nang. So we'll see. But the symptoms, if you got someone coming back from an endemic area, if this woman have symptoms that developed within 14 days of return, then you wait for another week and you ask for serology and PCR in blood and urine. If all this is negative, that's fine. She's got something else. If it's positive, then you would move for ultrasound, amniocentesis with PCR, but the PCR, Marianne mentioned that it was not that specific and sensitive, sorry. Again, there's a correlation between persistent maternal viremia and fetal damage. So that's something to take into account. If this woman had positive history without symptoms, when she comes back from the whatever trip, honeymoon usually, you get an immediate serology. And if it's negative, you don't look at it anymore. If it is positive, you go on the right side of the slide and go through everything. And if she has no history whatsoever, and she had a serology a month later, if she's worried, you do a serology 1 month after she returns, because you don't have symptoms to orientate the dating. And again, it will be negative nearly for sure, and that'd be irrelevant. And if it's positive, then you move to the diagnostic pathway and only prognostic evaluation, because unfortunately there's no treatment. And thank you for your attention.
Xin trân trọng cảm ơn với bài báo cáo rất tỉ mỉ, chi tiết, bổ ích và lý thú về bất thường thai nhi trong trường hợp thai bị nhiễm trùng. Trong lúc chờ các anh chị học viên đặt câu hỏi, tôi xin đọc câu hỏi của anh Hoàng Long tham gia online. Anh Hoàng Long đặt câu hỏi này trước khi giáo sư Yvonne giảng bài này. Chắc là sau khi nghe bài giảng xong thì anh Hoàng Long cũng đã hiểu ra một số vấn đề. Tuy nhiên là tôi đặt câu hỏi của anh Hoàng Long để giáo sư Yvin giải thích rõ hơn ạ. Khi thai bị nhiễm trùng bào thai thì có thể xuất hiện các bất thường gì trên hình thái thai nhi và trên siêu âm có những bất thường như thế nào thì gợi ý là nhiễm trùng bào thai. Xin cảm ơn giáo sư ạ. Vâng, xin trân trọng cảm ơn giáo sư. Câu hỏi từ chị Mai Quỳnh Đặng có hai câu hỏi. Câu hỏi thứ nhất là làm thế nào để chẩn đoán gan to, lách to trên siêu mạng, chẩn đoán ruột tăng âm so với cấu trúc gì và làm thế nào để đánh giá. Cái phần này đã có trong phần giảng của giáo sư rồi. Trân trọng mời giáo sư giải thích rõ thêm ạ.
Okay, so hepatomegaly, you look at the features in a parasagittal scan, parasagittal view. Therefore, what you will image is the right lobe of the liver, and the landmarks are below is the gallbladder, and above is the diaphragm. And you go with a straight line parallel to the spine to measure this. And roughly anything below 30 millimeter, late second, early third trimester is normal. The spleen, it's a transverse view of the abdomen, the one you use for abdominal circumference measurement. Usually, if there is splenomegaly, an indirect sign is that the stomach bubble is one small and two pushed to the middle. On this view, the spleen has a mango shape, and you have three landmarks: the stomach bubble, the lowest rib, and the spine. That's in this triangle that you find or you don't find the spleen. If you don't find the spleen, that's good. If you find it, it's not always a problem. Far from that. A big baby has got a big spleen, that's normal. And you measure the largest diameter of this mango. And again, you put it on the chart, and anything that is below 30 millimeter, late second, early third trimester is normal.
Xin câu hỏi thứ hai của chị Mai Quỳnh Đặng ạ, là nếu thấy ruột tăng âm đơn độc thì có cần phải làm gì thêm không ạ?
So the bowel, again, I don't know about cystic fibrosis in Vietnam. I know there are specific mutations, so most probably you check for that in the parents. So that's, you can't really go without that, I don't think. Then you check what you did in the first and second trimester about aneuploidies. Then you go through morphological examination and biometry. Biometry normal, morphological examination normal. We would do serologies and we would stop there if it's normal. You may also, if screening for aneuploidy was not great, if the anatomy is not satisfactory, we would go for an amnio and we go directly for RAs. We don't do karyotype anymore in Necker. We go straight for RA. But the vast majority of the cases of these hyperechogenic bowel are just normal findings. Again, use a semi-quantitative assessment by looking at the bones and the bowel. And only when the bowel is as echogenic or more echogenic than the bone, meaning that switching gradually the gain down to zero, all black, the bowel image goes before the bone. This is not hyperechogenic bowel. And if it is, ask one question about bleeding in early pregnancy, because most cases of irrelevant hyperechogenic bowel are related to early bleeding in pregnancy and the passage of blood in the amniotic fluid. And if you shake gently the uterus, like you would do with the Eiffel Tower in a small glass, you would see the flakes of the blood moving around.
Câu hỏi thứ ba gửi tới giáo sư của chị Mai Quỳnh Đặng ạ, là khi thai có biểu hiện giãn não thất, vôi hóa thành não thất kèm theo loạn sản khe synovial đã được chẩn đoán trên chụp MRI, Kèm theo thai đó có tràn dịch màng phổi, một thời gian sau tiến triển thêm tràn dịch màng bụng. Thai đó đã được chọc ối làm tóc và cho kết quả là âm tính. Vậy có thể nghĩ tới nguyên nhân gì nữa không ạ?
Yeah, well, torch, there's not much light coming out of torch in some cases because torch is toxo, it's rubella, it's CMV, and it's herpes. It could be enteroviruses. That would be something, and enteroviruses are not easy to diagnose because their investigation would be very specific. So you may not be able, it could be Zika as well, but you may not be able to put a clear label on this one. But also you have genetic conditions mimicking infections. And this is known in pediatric pathology as the name escapes. Hopefully that's the jet lag and not Alzheimer. But just right now, I can't remember this. It's a pediatrician from Necker, the pseudo CMV genetic. Anyway, that will come back at some point. But it could be a genetic. It could be a genetic disease. So you just Google, just Google it. Pseudo CMV genetic disease. You will find the name of this pediatrician who died a few years ago. And so that could be genetic. It's not, even when all the criteria for infection are there, it's not always infectious. And in any case, the most important here is the prognosis. And from what you described from the brain, prognosis is dismal for sure, because brain atrophy and abnormal gyration is bad news.
Sorry, I have a question. When you see severe signs on neuroimaging, for example, periventricular hyperechogenicity, do you recommend to start treatment because they have severe signs of neurolescence? So in such cases, does the treatment make difference between no and have treatments?
Yeah, if you don't have clear white matter lesions, so periventricular leukomalacia or thick periventricular hyperechogenicity, if it's just the ventricles that they may look bright also because they are dilated sometimes. It's just an artifact technically. So yeah, there is no wrong done or harm done by starting the treatment, especially if this patient is motivated. So yeah, this is if you know it's an infection though, because you don't go blindly for that. You need to make sure it's an infection. Yeah. And yeah, for CMV, because that's what treatment, the only treatment we've got. So. Go ahead.
Xin cảm ơn ba bài báo cáo liên quan đến vấn đề nhiễm trùng ở bào thai và lây truyền nhiễm trùng này sang con. Tôi xin có một câu hỏi tổng thể như thế này. Ở trong quý 1 thì chúng ta thường chẩn đoán cái nhiễm trùng bào thai này bằng các xét nghiệm miễn dịch. Và các xét nghiệm đó đã đủ để cho chúng ta thực hiện một liệu trình điều trị. Và nếu thực sự những thuốc điều trị nó không ảnh hưởng đến thai nhi về sau này, thì có lẽ chúng ta sẽ phải điều trị từ quý 1. Vì nếu chúng ta chờ sang quý 2 mới điều trị thì tỷ lệ tai biến cho bào thai, những cái bất thường về bào thai nó lên tới 30%. Vậy thì có lẽ chúng ta sẽ phải là điều trị chứ không thể chờ đợi đến quý 2. Và nếu đã điều trị từ quý 1 thì có cần thiết phải sang quý 2 chúng ta làm một biện pháp chẩn đoán là chọc nước ối, lấy mẫu ối để phân tích mẫu ối nữa hay không? Đấy là câu hỏi tiếp theo. Và có một vấn đề nữa, đó là những trường hợp mà tái nhiễm, tức là sau khi đã điều trị khỏi ở quý 1 rồi, thậm chí quý 2 rồi, họ lại bị nhiễm trùng tiếp, thì cái việc điều trị về sau này có cần thiết không? Tất cả những cái can thiệp vào buồng tử cung, mặc dù lấy mẫu ối là rất ít tai biến, ít nguy cơ, nếu không phải là để nghiên cứu mà chỉ là để chẩn đoán, thì ở quý 1 nếu chúng ta đã chẩn đoán rồi, chúng ta đã điều trị rồi, thì tôi cho rằng là cái câu hỏi này cũng xin hỏi các giáo sư và các báo cáo viên là có cần thiết phải làm thêm ở quý 2, và những trường hợp tái nhiễm mà họ bị tái nhiễm thì chúng ta có điều trị tiếp hay không? Xin câu hỏi như vậy.
So as I said before, we recommend to perform a screening of CMV in the first trimester because when the mother is contaminated in the early pregnancy, the thing is, if you start as soon as possible the treatments, then you will see a decrease of the risk of vertical transmission. So this is why you should implement the treatment as soon as possible. And if you perform the serology testing during the first ultrasound, patients are used to do an ultrasound at 5 or 6 weeks to just confirm the pregnancy. And it is the target for the timing of serology testing. And if you observe a maternal contamination, then you should start the treatment. And then we really recommend to perform an amniocentesis at least 6-8 weeks after the estimated date of maternal infection and after 17 weeks of gestation to confirm or to check for the fetal infection. And if it is positive, then you should start or implement the treatment with valacyclovir. It is the same. And it will decrease the risk of sequelae. And if the PCR is negative and you have done the amniocentesis in good condition, so you can stop the valacyclovir because you have the proof that the baby was not infected during the first trimester. In approximately 8%, 10%, the baby will be born with positive PCR, so you would say that he is infected, and it is not a false negative of the amniocentesis. It's just that the virus went through the placenta after the date of amniocentesis, so during the second or the third trimester. But as Mayan showed, we have now a lot of data about the false negative of amniocentesis, and there are no risk of sequelae for these children.
The part of the question on non-primary infection, hopefully with the CMV study, we will be able to answer in a few years, because there is currently no way to diagnose beginning of a non-primary infection. So one, we will see what the seroprevalence is in Vietnam, which is missing. It is expected to be high, but we'll see. Also, there might be differences in different category of the population. And certainly for those that are immune, we will see babies infected. And hopefully from this, we will learn how to diagnose non-primary infection, which so far is a complete black box. There's nothing.